All right, thanks everyone. BG Rathakrishnan, one of the cardiology fellows at Beth Israel. So talking about a case from our lab earlier this year. So this is actually a 57-year-old gentleman, very healthy, just a history of GERD and prior remote testicular cancer, who was actually visiting Boston for an online MBA course. Really no prior history of any tobacco, alcohol, or drug use, and not on any medicines at home, just an occasional PPI. Had an episode of chest pain and malaise the morning of admission, which prompted him to activate EMS and eventually come to the ED. So here are kind of his initial vitals when he gets to the ED, and kind of thinking about some of our criteria from this morning about the different stages of cardiogenic shock, a lot of risk factors already. So pretty hypotensive with a narrow pulse pressure, was very bradycardic, already requiring oxygen, and pretty ill appearing. Kind of the other notable things was some signs of volume overload, both with pulmonary edema as well as in his lower extremities, and was cold to the touch. He was actually initially mentating, but kind of worsens pretty dramatically in the ED. Develops worsening bradycardia. They had to start atropine and actually initiate him on transcutaneous pacing at that time. So here's actually his kind of first EMS strip, and kind of when he first gets to the ED. So you can see there's actually already a complete heart block here, and it looks like he's got some elevations both in the lateral as well as in the anterior leads. And in the setting of this in the ED, kind of really rapidly deteriorates, has worsening respiratory distress. This is really all over the course of 20 to 30 minutes, requiring intubation. And then during this intubation attempt in the ED, actually suffers both a VFib and then polymorphic VT arrest. So CPR is kind of started, and at this time, the cath lab gets activated for emergent transfer. And then when he gets to the cath lab, a couple of things happen. So first, has a temporary transvenous pacemaker placed. Started on that for his complete heart block. Starts mechanical support with an Impella CP catheter, and then kind of discussion in the cath lab, as we've discussed kind of this morning, in terms of the whole shock team, has both the heart failure team there, our CCU team, and the interventionalist discussing about options for support and what he needs. So after all of that, upgraded to VA ECMO through the right femoral artery and the right femoral vein. And then at this time, you can see here, starting first at the left-sided system, you can see a pretty extensive proximal LAD occlusion. You can already see the Impella and the temporary pacer in place. And does also have some right-sided disease as well. So I think we've kind of discussed, and you can hear kind of going through the intervention across the lesion. You can see kind of how much territory is supplied by the LAD. And then looking toward our end result after, I think, 2 stents were placed to the proximal LAD at this time. So I think we've discussed this, in terms of our polling options, in terms of kind of the antiplatelet. Just for the sake of time, we'll say that he ended up getting loaded with IV cangrelor, 100% stenosis of the proximal LAD, as well as in the RPDA, and these 2 stents that were placed there overlapping. And something that, as Eric and Dwayne have kind of pointed out in our lab many times, they like to show this to us, especially when we're first-year fellows, kind of really freaking out on the phone about antiplatelet in the ED options. And then just to kind of briefly go over his ultrasound, so you can see very severe global hypokinesis initially when he gets to the CVICU, and kind of gradually over his stay in the next couple of days, some improvement. But even, I think, by the time he left the hospital, his EF had only improved to about 25%. So just going through the rest of his clinical course, had a pretty prolonged ICU stay, complicated by renal failure, requiring CRT, had significant bleeding surrounding the ECMO cannulation sites, requiring FFP, I think surgical catheter adjustment, and then AFib as well. But eventually tolerates sequential both Impella and ECMO weans with extubation and renal recovery, transferred out of the ICU, and was eventually discharged to rehab after about 3 or 4 weeks in the hospital on DAPT with aspirin and ticagrelor. Thank you.
Well, that was another great case. So we'll just have a panel discussion. We've got 10 minutes. Fortunately, all the speakers kept to time. If there are any questions, though, from the audience, please line up behind that mic or that mic there, and we'll try to take all the questions. It was a great point that you raised, Tim, about ISAR React 5, because for those of you that weren't in Paris, it was published in New England Journal of Medicine. and showed not only non-inferiority but actually superiority of a strategy of prasugrel versus ticagrelor. I'll just provide my own very quick commentary on that. It's an important decision because prasugrel is going generic, or actually it's already gone generic.
Population for the audience?
What's that?
The patient population, can you go through that?
Yeah, it was a mixture of STEMI and NSTEMI type patients, and there was a mixture of, so one problem with the trials was an asymmetric randomization, that is, it was ticagrelor and prasugrel. The STEMI patients were treated similarly, but the NSTEMI patients got pre-treated in the ticagrelor arm and post-treated in the prasugrel arm. And if you're like me and skeptical of the value of oral pre-treatment in NSTEMI, then that biases against ticagrelor. The ACOST trial, if you recall, studied 4,000 patients with NSTEMI prasugrel pretreatment versus none, and the DSMB stopped the trial early because of excess bleeding with prasugrel pretreatment and no benefit in the context of NSTEMI. So that's one sort of critique I would raise about SR-React-5. But it's an important question because prasugrel has been generic for a while, but now the price is actually starting to drop, at least in this region of the country. I don't know if it's true of you as well, Eric. I've been getting lots of these sorts of calls from the third-party payers, pharmacy benefits managers saying no to ticagrelor or have to use prasugrel. It's in the preferred tier. So it's an important decision now because the cost is changing. That is, ticagrelor remaining branded, but prasugrel now going fully generic. But the other critique I had of SR-React-5, other than the fact that the two arms have that asymmetry, is that the degree of benefit seen was enormous. It's actually more than the benefit seen with clopidogrel versus placebo, which to me is implausible. You know, my own interpretation of the prasugrel, ticagrelor, PK/PD data is they're basically the same. Maybe marginally better. You were showing, I don't know that I necessarily agree, but regardless, it's not whoppingly better. So, you know, even if there's more adherence issues because of dyspnea with ticagrelor, even if 50% of the patients were non-adherent at some point, I wouldn't have expected that degree of a difference. So it makes me skeptical. There were also some other imbalances in terms of the number of patients, follow-up, missing data. But I'd be interested to hear what others on the panel think about that.
A number of points. First of all, before I forget it, another group of patients that is really important to think is when you do get stent thrombosis, or when you do get slow flow, then my own personal experience and seeing cases is I think that's a great place for IV for Canglor. And I really seen some almost magical cases where, you know, you give it and melt, and that's in particular, you can have slow flow for multiple reasons, but if your slow flow is because of inadequate antiplatelet therapy, then it's really effective. And the second is, there's always this debate about IV Canglor versus 2B3 inhibitors, and personally, it's just the bleeding issue. Especially for out-of-hospital cardiac arrest and cardiogenic shock, the ECMO patient, the Impella patient, bleeding is your enemy. And Deepak showed it. I think that the data still clearly shows 2B3 inhibitors have more bleeding than Canglor. Canglor has some for sure, but it's pretty small. It's really, my experience is it's severe bleeding is really unusual. So I think that's a good group to remember. Just as general comments about the prasugrel. And I think for everyone to have this, I think for STEMI, there's no reason not to give a P2Y12 as early as possible. The number of people that go to surgery are small. You want antiplatelet on board. For non-STEMI, I completely agree with you. I think the standard is pre-treatment is not. And in non-STEMI, 10 to 15% of those people will need surgery. So STEMI and non-STEMI are different diseases and approaches to that. That being said, the good thing about ticagrelor has been with that you don't have the black box warning, and you have the compatible with Canglor issues, which make it really easy to put in standardized protocols. The problem is what we want to do in a regional STEMI system, you have a standardized protocol for 35 hospitals. I want the P2IUN12 on board, and with ticagrelor, give it to everybody. But with prasugrel, you have all of this issue about did you have a previous stroke or TIA. So and maybe it's not even a fair difference between the two, but it is a black box warning and it complicates it.
Yeah, I mean, I think there's no question that there's many examples of how if something is sort of equivocal or there's marginal benefit or unclear benefit, or maybe one trial that suggests something, but from a practical standpoint, it's not going to be generalizable like that, and so you're going to get much better benefit for patients by doing something that's much more generalizable, like going straight to Brilinta and then moving into Cangrelor.
Yeah, I agree. Though, with the interactions, it's and labeling, it's a little tricky. I favor ticagrelor. At the Brigham, we're predominantly using that in our ACS patients, STEMI or NSTEMI. But if you did use prasugrel or clopidogrel up front, and that's already on board in the patient and it's already been absorbed, of course the platelet now is irreversibly antagonized, and then adding Cangrelor to that is okay. It's the only time there's a potential interaction is if you've just given clopidogrel or prasugrel, the active metabolite is peaking and is in the blood, and then the Cangrelors that are saturating the receptor, and then the active metabolite is gone away. That's the one time you can run into trouble, and that's why the labeling says in general to give that loading dose of clopidogrel and prasugrel at the end of the Cangrelor infusion, whereas you could give ticagrelor anyway. But if it's steady-state clopidogrel or prasugrel, then the PK/PD would allow use of Cangrelor. It's a subtle point, but it's important if you are using prasugrel as your foundational oral antiplatelet. You made a good point about bleeding with respect to 2B3 inhibitors and Cangrelor. I mean, I think in the present era, I don't personally think there's a good reason to use a 2B3 inhibitor instead of Cangrelor. I think if you're reaching for something more, I would reach for Cangrelor, assuming it's on the formulary. If it isn't, then I think in really high-risk patients, there's still a role for 2B3 inhibitors. And the bleeding, it's an issue because we're talking at this meeting more broadly about, Impella and ECMO use, which are really quite useful in patients that are going down the tubes. But there, I think Cangrelor is particularly attractive because, of course, an issue with both ECMO and Impella is groin bleeding. And, a short-acting agent like Cangrelor, even if you run into bleeding, within an hour of turning it off, even if the renal and hepatic function are impaired, it's essentially completely out of the system. The one caveat I'll make if people are unfamiliar is that the dose for PCI in terms of the infusion is much higher than the dose for bridging. So in general, if you've got someone on ECMO or Impella and you're continuing a bridging type dose, it should be the 0.75 mics per kg per minute, not the 4 mics per kg per minute that you would use post PCI, unless you're purposely wanting to, amp up their degree of antiplatelet effect. But otherwise, you don't want to accidentally continue that full PCI dose, for the next week in someone that's all lined up.
There's one other thing I want to take. In Bharath's case, I brought this up. The other really high-risk patient population where I think is perfect for Cangrelor is in-hospital STEMI. So if you look, the highest risk place to have a STEMI is in the hospital, and the worst mortality is that. And so who does that include? Post-op patients, patients with stent thrombosis, patients who got admitted after a treadmill and now have ST elevation. In that patient population, personally, I think Cangrelor is perfect, and because you get immediate treatment, and they clearly are the highest risk patient. And I think it's that case you showed where someone's so sick and they're arresting, and you're putting in an Impella. We have so much attention to the big things. Sometimes the appropriate antiplatelet is forgotten about. And the worst thing that could have happened to you in that case is if you had slow flow in the LED. If you had and you saw how quickly, we forget about all this. The most important thing we do in STEMI is reperfuse. That's what primary PCI does. That means you need to get TIMI3 flow in the culprit vessel, and then your LV recovers. So it's the most essential part of it, and that's a great case that you did, and you saw the LV recover quickly.
Yeah, I think those are really great points, and with ECMO at least, not with Impella, at our place there's often cohorting of the patients. That is, if you get ECMO, in the cath lab, or for a CCU patient, they tend to be cohorted with the folks that are getting, their lung transplants or ECMO post-surgery. So it's often then not in the CCU that they're cared for. So particularly important because they may not even be as familiar with things like ticagrelor or crush it and put it down the OG tube, or Canglor dosing and what's the difference between PCI. So really want to stay on top of that issue throughout that patient's hospital stay. Otherwise there can be all sorts of dosing errors.
Let me ask one more question about the window and the infusion. So at our institution, we give ticagrelor pretty routinely, and then we let if we do use Cangrelor, we'll let the infusion run for a while, giving some time for the ticagrelor to kick in. What do you do with these? If you're going to use Prasugrel or Plavix, you kind of want to stop the infusion earlier rather than later, and load the medication, or do you run it and then load it at the end? What is the ideal situation to minimize the at-risk time period?
The gap.
Yeah, I mean, per the U.S. labeling for clopidogrel or prasugrel, you would want to give the loading dose, 600 of clopidogrel or 60 of prasugrel, at the end of the Canglor infusion, whenever you choose to end it. Yeah, so if you, for some reason, typically you go a couple hours post-PCI, but if for some reason you wanted to go longer,
Right.
you're worried about slow flow or some angiographic complication or going longer, or the patient's unable to absorb for that period of time, you would give it whenever you end the infusion. So the 4 mics per kg
Right.
dose
So the
is
infusion is variable based on the weight of the patient in terms of how long whereas the risk is obviously more upfront. So it becomes an issue a little bit, I guess. Do you keep it going longer in patients who it would be running out early, the bottle?
So this is just we don't have data for any of this. This is just pure practical.
Right.
Here, I run it out. I use the Cangrelor as long as you have it, finish the infusion, and then do it. It doesn't make sense to me to stop it faster. But then the second question is, if I have an adequate result, I also wouldn't use a second vial. I mean, I run it out.
Yeah, I basically, this is
That's
more a
what we do, right.
practical question of how long the vial goes than specifically having to do with data, but yeah, practically speaking, I do the same thing.
And if you're using ticagrelor, it doesn't matter anyway. You're going to load it anytime during the infusion.
Yeah, so
anyway.
if ticagrelor is your agent, you could load before, during, or after a Canglor infusion, because it is at least at the receptor level, a reversible oral agent. It doesn't mean it's reversible in terms of ticagrelor is immediately out of your system, obviously, but in terms of its receptor kinetics, it's reversible, so the Canglor is there, the ticagrelor is there, and they're happy with one another. Whereas with clopidogrel and prasugrel, those are irreversible agents that bind to the ADP receptor for the life of that platelet. And it doesn't matter then if you add Canglor in that steady state, that's okay. It'll saturate the rest of the receptors. But if it's that active metabolite of prasugrel or clopidogrel that are wanting to get on that receptor, but Canglor is already there, that's when you can run into trouble. So bottom line is just give that loading dose of clopidogrel and prasugrel at the end of the infusion, unless it's a patient that's already on stable, long-term, steady-state clopidogrel or prasugrel, then it'd be okay as well. We have one question. That's probably all we've got time for.
We don't have Cangrelor on formulary in pharmacies, so in our department we discussed that amongst our partners, and we thought the way to balance risks and benefits of 2B3A is to just give a bolus, no drip. That kind of hits a sweet spot between the bleeding risk and the bridging issue. I was wondering if any of you using just a bolus to bridge for the oral P2Y12 onset.
It's a great question. I think maybe a short answer from everyone who wants to opine would be good. I think that the bolus infusion strategy for 2B3 inhibitors is being widely used in those that are still using 2B3 inhibitors as the bolus only. But really all the good data, and there was tremendous data for 2B3 inhibitors versus placebo, largely in the aspirin-heparin era, was really bolus and prolonged infusion. There were some smaller biomarker-powered studies looking at biomarker elevation post-PCI that showed comparability of the bolus only versus bolus and infusion, but not powered for clinical events. So that really robust data for 2B3 inhibitors is with the infusions. But the issue with 2B3A is there's still that bleeding hazard. That is, when you turn it off, the effect still lingers for several hours. So if you run into a bleeding complication, you can't easily reverse it with abciximab rituximab, you can transfuse platelets, and then you may need to retransfuse. But in particular, eptifibatide and tirofiban, you're kind of in a bind for that period while they're still on board. And if we're talking about cardiogenic shock and potentially prolonging an infusion while the patient's intubated and not absorbing and so forth, there you're back to an infusion and all the sort of bleeding hazard that confers. The real advantage with Canglor is if you're choosing to continue it, especially in that sick CCU patient, that if they run into bleeding, literally turning it off, it's out of the system within an hour, so it really does minimize the bleeding hazard. But I'd be interested to hear what the rest of you all think about that. Good question.
Yeah, I mean, I think those are all great points. I mean, those aren't free either, right? So you're taking an upfront cost for those. There's also the risk of thrombocytopenia and such, so that's something to be considered. So, I mean, I think Canglor just overall, I think gives just a better profile. If there is bleeding issues, you can turn it off. I think in Bharath's case, like going down to a lower dose allows you to sort of manage some of those groin bleeds like you saw. So I think there's just a lot of benefits for those fast on-off kinetics. And, I think we're using it more in our sick STEMI patients than we did. We protocolized upfront ticagrelor, but, we're seeing more and more use at our institution of Canglor because these patients are really at risk.
The first argument is the best one, which is that they're not free either. And so if you tell them that it's you're going to use one or the other, you're likely not to use both. It should be get through your pharmacy committee.